Hi guys, welcome to yet another episode of Guideline Review of the Week. Today I shall be discussing a topic that not many are aware about. It is a topic that I personally have not been aware about until I read about it just prior to my exams. I knew that there are guidelines that existed for this, but I never really put it into practice. And there was a set protocol that I used to follow for patients who came to me in preterm labor, but I never knew really why am I doing it. So today, this lecture, this review of the guideline is going to be for everyone, especially all the residents who are watching it, because this is a very important topic. US and UK have a great framework. They have a great protocol that they already have into existence since a long time for this disorder, for this disease, for this condition. Indians have taken a bit out of it, but not put it much into practice, I believe. And hence, I hope at the end of this lecture, you will be a lot more aware about this topic. And the topic today is going to be Group B Streptococcus and pregnancy. This topic is yet again from my favorite by now, Green Top Guideline from Royal College of Obstetricians and Gynecologists, and this is a guideline that was started in 2017. So there have not been many changes in it really. So let us proceed with it and let's know what is it about. For starters, सबसे पहले basics की मैं बात करूंगा. The basics include what is Group B Streptococcus. So we have read in microbiology in our second year of MBBS that when I talk about microbiology, there are several bacteria, and they are first of all assigned a specific class on the basis of the structure that we see under the microscope. So when I talk of streptococcus, coccus in first place means a circular body, circular structure. Now when I'm arranging this circular structure in a strip or in a straight line, in a linear line, I call this streptococcus. We also have staphylococcus. That staphyle is another word for grapes. So उसमें रहेगा ऐसे नीचे बनेंगे, अंगूर जैसे बनेगा. But today we are going to be talking classically about streptococcus, in which all these cocci are arranged in a linear sequence. उसमें what is this group B? So when I talk of streptococcus, so I'm going to just write it as streptococcus, strepto C. उसमें on the basis of hemolysis that it does on blood agar, you remember that we had something like blood agar जिसमें there used to be actual blood and उसमें hemolysis होता था. So when I used to put it in that culture medium, there used to be three different types of hemolysis that were seen. उसमें से the major ones were alpha hemolysis, beta hemolysis and gamma hemolysis. So alpha and beta were the major ones. उसमें alpha वाला जो था, it was partial hemolysis. Whereas beta वाला जो था वो था complete hemolysis. So ये दो major वाले थे. So when I was talking about beta hemolysis that was occurring, that was complete hemolysis, a complete transparent zone was made in the agar, and Lancefield decided कि on the basis, by the way, streptococcus is gram positive, never forget that. So Lancefield said that not just gram positivity, but on the basis of an enzyme and how do they react to it, I would classify them further into various groups. So Lancefield decided to put it into various groups for the ones that were catalase negative. So उसमें there were many groups, A से लेके H तक थे. उसमें से तो जो सबसे important था वो था Group A and Group B. So Group A and Group B were the more important ones. There were many more. Group D is the third important one, जिसमें Enterococcus आता है. So ऐसे नहीं कि Group H तक significant वाले groups बनाए गए थे. So उसमें when I talk of Group A, the more significant ones that come under it was Streptococcus pyogenes and Streptococcus viridans. Whereas Group B में आता था Streptococcus agalactiae. And this is going to be the topic of our discussion today. Streptococcus agalactiae. Group B Streptococcus is this. So basically beta hemolysis के नीचे Lancefield classification wise Group B Streptococcus में आता है A galactose है. Just to tell you all कि you all will obviously remember कि ये अल्फा के नीचे क्या आता है. अल्फा के नीचे भी एक बहुत ही famous celebrity आता है and that is Streptococcus pneumoniae. We have already spoken about this, talked about this Streptococcus pneumoniae in an earlier lecture, and today I'll be focusing only on Streptococcus agalactiae. So the first question is, itna specific thing, Streptococcus B, Group B Streptococcus, why do I need to discuss about it? So the intention is that it is recognized as the most frequent cause of early onset infection in newborn infants. So if I'm going to be talking about infection in infants, or what I can also call as neonatal sepsis, based on कब हो रहा है, when is it presenting, it can either be early onset or it can be late onset. If I'm talking about early onset, it is anything that occurs in the first 7 days of life, whereas late onset is anything that occurs after 7 days of life. So the most common cause of early onset neonatal sepsis was this Group B Streptococcus, which is Streptococcus agalactiae. So it was recognized that this is a very important one and we need to recognize it. And if it is early onset, it indicates that it is something that the baby has acquired inside the uterus while it is still inside the mother. Whereas the late onset, they are mostly the ones that the baby has acquired from the community, that the baby has probably acquired in the hospital or from the community, and it is not much related to the intrauterine environment that it was in. And hence, neonatal sepsis of the early onset was something that could be prevented, because if the mother is not infected or the mother is not getting or contacting that bacteria, then the baby could also be salvaged or prevented from getting this kind of early onset sepsis. So where is this Group B Streptococcus or Streptococcus agalactiae? Both are the same. मैं पूरे इसमें I would use either of those two nomenclatures. So Group B Streptococcus is present in the bowel flora of 20 to 40% of adults. Now, we call it colonization. We can also call it commensals, but commensals indicate something that is present in every person. This is not present in every person. At most 20 to 40% pregnant women में ही रहता है, and it is not just the bowel flora, it is the gastrointestinal, which is bowel, plus the genitourinary tract as well. So these are the two places in which it is present. So whenever is it present, we call these women as carriers of Group B Streptococcus, and obviously it also includes pregnant women. So before moving on, there is a small point that they've put pehle hi regarding vaccination. Before learning all the details, do we have a vaccine against this? A vaccine would prevent all the complications. So yes, we do have a vaccine, but the problem is that there are multiple strains that we get. There are 10 active strains that we get, and currently the maximum that we have is only a pentavalent formulation. So it still leaves 5 more strains that are not covered under this vaccine, and hence this vaccine, though is an acceptable option, it is not yet used as prolifically as it can potentially be. Probably in years to come, we shall have this vaccine that is available for use. So antenatally, should all women be offered bacteriological screening for GBS? Now, this is the question that makes you think as to why don't we test all the women for this Group B Streptococcus. So there are differing views of ACOG, that is American College of Obstetricians and Gynecologists, and RCOG. What we are studying right now is RCOG. I'll also tell you what does ACOG say. So if I'm talking right now about RCOG, they say that universal screening is not recommended. ACOG, now this is obviously RCOG, इसलिए मैं RCOG यहाँ लिखता हूँ. जो ACOG है, it has differing views. ACOG says that universal screening should be done. So universal screening should be done is what they say. This is the first point. So why does RCOG say that we should not screen it universally? So the first major reason is, by the way, if you are going to go back to our basics of screening, कि हम लोग screening किसका करते हैं, क्यों करते हैं, that we have studied in community medicine. Screening is done for those patients, for those disorders in which we have a definitive treatment that is available, and if we don't give that treatment, there is going to be a large scale disease that, or a large number of people, a large number of population that might get affected by it. So screening has to be something that affects a lot of patients, and we have a cure for all of them. इसमें ये पहला प्रॉब्लम था that many women carry this bacteria obviously, but in the majority of the cases the babies are born safely and they do not develop any infection. So the first thing is ये screening का कुछ मतलब नहीं बनता है they say, because though 40% of females might have colonies of this bacteria, but not 40% of women have babies which have this infection. Secondly, screening अगर कर भी ले, we are not able to detect कौन से बेबीज में GBS होगा. सो इनका ये मतलब है कि इन विमेन जिनमें स्क्रीन नेगेटिव आता है, इनमें वो कोलोनेशन नहीं मिलता है, even those babies have had Group B Streptococcal infection. Hence that screening did not make any sense and it was only using up all the resources, increasing the cost, unnecessary investigations were being done for it, and hence उसका कोई point नहीं है. And its accuracy was always in question. And lastly, a large number of women would receive a treatment. Now, the treatment for any gram-positive bacteria is with penicillin. The first line drug, the drug of choice is penicillin. And penicillin is notorious to cause anaphylaxis. Now, if I'm going to be giving all these women who have colonies of GBS, I'm going to give them penicillin, they will have anaphylaxis. But as I just said, that not all the women have babies who have the infection. So I'm unnecessarily giving the patient an increased risk of antibiotic-related adverse effect without much benefit to her. Also, the possibility, the risk of increased resistance to that antibiotic for no good, for no benefit, definite benefit was also occurring, and hence the screening program was not put in place and they say कि जरूरत नहीं है. What does ACOG say though? ACOG says कि universally हर एक female का screening करना चाहिए between 35 to 37 weeks. The screening has to be on the basis of two things. The two things include, सबसे पहले कल्चर करो और रिस्क फैक्टर्स देखो. Now risk factors is what even RCOG says कि सिर्फ जिनमें risk factors present है उनका ही करो. So the additional part of ACOG is that they say कि सबका कल्चर्स किया करो. कौन सा कल्चर करना है? एक तो यूरिन का करना है and secondly एनो-वजाइनल करना है. We'll be reading a bit more about it later on. So what are the risk factors in which you should think of screening these women, which is something that ACOG and RCOG both agree on? So if the patient gives history of a previous baby with GBS. Now the problem with Indian patients is that a lot of women who are under the low socioeconomic strata, they don't have records of their previous deliveries. Let alone their babies, उनका खुद का भी record नहीं होता है, तो baby का क्या ही file maintain करेंगे. I have had so many patients who just say कि I stay in Mumbai, so we often get floods every year. So the commonest excuse that every female gives is that हमारा घर में बाढ़ आ गया था और उसमें वो file चला गया. I mean, I don't understand. Like, do you keep a file randomly on a floor? And how can you end up losing a file that is so important to you, that talks about your obstetric history? But unfortunately, we have so many women who just misplace their papers and we have no access to it. So we don't know what was the baby's outcome in the previous pregnancy. The best possible history that she can orally give you is probably I had a neonatal death in my last pregnancy, my baby died after birth, and you ask her as to what happened, then she'll say that the baby was in the ICU, the baby probably had some fever ka bouts, but then the baby succumbed. Or the baby did not succumb, but it did have fever after delivery and it was in the ICU for a long period of time. So this history might point towards a previous baby that had Group B Streptococcal infection. Obviously, if you have papers available, baby के papers है उसमें दिया गया है कि Group B Streptococcus है, तो definitely it makes your work easier. But in women who don't give you those papers, you can ask this history कि baby को delivery के बाद ICU में रखना पड़ा था. अगर रखा था तो बुखार आ रहा था, उसको उल्टी हो रही थी, बच्चा ढीला लग रहा था. I mean, the baby was floppy, flabby in your hands. It will give you an insight and idea whether the baby had Group B Streptococcus infection. Apart from that, if we were to test a female was saying that I am having burning micturition. So I did a urine routine test for her और वो urine routine में आया bacteria. I decided to do a culture और वो culture में accidentally पता चला that the female has Group B Streptococcus. So discovery of maternal Group B Streptococcus carriage through bacteriological investigation during pregnancy. It was accidentally done. It was done for a urine infection or a swab was taken for a vaginal discharge. So basically it was an unrelated event. Vaginal discharge था, UTI था, I tested her. उसमें accidentally पता चलेगा कि इसको Group B Streptococcus. So accidental discovery. If a female is presented to me in preterm birth, it's been evidentially said that women who come in preterm labor, they are in preterm labor mostly because the biggest reason is because they have some infection, and the biggest infection or the most common infection is Group B Streptococcus. So unless proven otherwise, if a female is coming to you in preterm labor, and obviously it's a singleton baby, it's not twin, अगर singleton है preterm labor में आती है, so there is a very high chance that the mother or the patient has Group B Streptococcus that has led to preterm labor. क्यों होगा infection से? Infections release cytokines. Cytokines lead to the release of prostaglandins. These prostaglandins lead to fever, pyrexia, which is also my last point over here. They lead to fever, as well as they lead to those prostaglandins also lead to uterine contractions. So premature uterine contractions will lead to preterm labor. Apart from that, prolonged rupture of membranes. So prolonged rupture of membranes, if the membranes have ruptured for a long time, the amniotic fluid is just flowing. So the lower vaginal tract, जहाँ पे ये Group B Streptococcus रहता है, remember I mentioned कि genitourinary tract में होता है. So ये जो lower genital tract है, ये उसमें जो भी बैक्टीरिया था वो अभी ऊपर जा सकता है because the amniotic membrane is broken. It can easily enter and it can lead to chorioamnionitis. So infection of the fetal membranes can occur. So all these are the risk factors. These are the clinical risk factors that appear to place women at an increased risk of having a baby with early onset Group B Streptococcus. So these are all those women who need to be kept under strict monitoring. So now, should a female be offered IAP is, by the way, intrapartum. Okay, so now a point. पता चल गया ये सबको रिस्क फैक्टर्स है. हाउ डू आई प्रिवेंट इट? वेरी इजी. इफ आई हैव टू प्रिवेंट इट, ऑल आई हैव टू गिव हर इज कीमोप्रोफाइलैक्सिस. कीमोप्रोफाइलैक्सिस यानी एंटीबायोटिक्स देना है. व्हाट वी आल्सो कॉल एज इंट्रापार्टम एंटीबायोटिक prophylaxis, IAP. You will see the use of this word very often iske aage bhi. So all I have to do is, whenever the patient is in labor, I have to give her this. Why is it important ki labor ki patient ko dena hai is answered in the next question. So if a female is detected with this at some point in her gestation, so should I be giving her antibiotics antenatally? Then no. The answer is during pregnancy antibiotics से कुछ मतलब नहीं है. क्यों? क्योंकि the GBS, the bacteria is not present inside the membranes already. It is present in the lower vaginal, the lower genital tract. So unless the baby's face, the baby's contact is coming in that lower genital region, which occurs in labor and not otherwise, antenatally there's no point of giving any antibiotic to the female क्योंकि उससे उसको reaction तो आएगा नहीं तो resistance होगा. So do not give it antenatally, give it when the patient is in labor. Hence we call it intrapartum antibiotic prophylaxis. It is not antenatal, it is only intrapartum. Apart from that, if the female is having any risk factors of the ones that I mentioned above, and if you're following ACOG guidelines which say कि universally सबका test करना है, so when should you be doing that test? It should ideally be carried out at 35 to 37 weeks of gestation, which is 3 to 5 weeks prior to the date of delivery. And if it's twins, then 32 to 34 weeks, क्योंकि twins थोड़े जल्दी पैदा होंगे. So 3 to 5 weeks prior to delivery, you should be doing this test. What is the test that you should be doing? You have two ways. मैंने जैसे बोला था, एक तो यूरिन कल्चर भेज सकते हो, and secondly this is urine culture sensitivity, or you can send a swab which contains anal region and lower vagina. So anovaginal swab can be sent to look for Group B Streptococcus. So how should now, assuming that I have done this urine culture और मेरे urine culture में आ गया है Group B Streptococcus, so how should I manage it? Now you need to understand that urine में कोई ना कोई तो बैक्टीरिया काफी बार रहता है. The female is also not giving me any signs or symptoms of urinary tract infection. So she might have asymptomatic bacteriuria. So how do I consider it significant? I consider it significant if the number of bacteria are more than 10 raised to 5. So 10 raised to 5 colony units अगर ज्यादा है तो ही जाके कॉलोनी फॉर्मिंग यूनिट्स अगर ज्यादा है, 10⁵ से ज्यादा है अगर नंबर्स ऑफ द बैक्टीरिया इन द यूरिन, देन ओनली इज शी अ कैंडिडेट of intrapartum antibiotic prophylaxis, and she should also receive treatment for her UTI immediately. Remember, we are not treating the carrier status here. Here we are treating the UTI, which is because of more than 10⁵. If it would have been less than 10⁵, I would have not treated it. I would have only given it during labor. So women with GBS bacteria should be offered intrapartum antibiotic prophylaxis. But if they have urinary tract infection that is more than 10 raised to 5, then they should receive antibiotic treatment during antenatal period as well as during labor. So if a female is having UTI, उसका कितना है देखो, अगर 10 raised to 5 है या फिर 10 raised to 5 से ज्यादा है. अगर कम है तो ओनली ड्यूरिंग लेबर देना है, अगर ज्यादा है तो एंटीनेटली भी देना है और इंट्रापार्टम भी देना है. वेरी सिंपल. सो यूटीआई विद जीबीएस. Same thing that I just mentioned, that antenatal treatment is not recommended for GBS cultured from vaginal or rectal swab. Only UTI को treat करना है. Vagina या rectum में positive आया तो you do not treat it. Next question is, if I have planned a cesarean section, should I be giving this females IAP? No. There is antibiotic prophylaxis for GBS is not required for women undergoing planned cesarean section in the absence of labor with intact membranes. मतलब if the baby is not coming in contact with the lower genital region, the vaginal regions, or there is no rupture of membranes, it's an elective cesarean section that I'm probably doing for CPD or previous cesarean with the patient not willing for trial of labor, or for placenta previa or accreta. These women do not need to be given antibiotics for GBS. You can give it if it's your hospital protocol, but do not give it for GBS because the baby is not coming in contact with the lower vagina. So only for patients who are having labor or who undergo cesarean section during labor are the ones who should receive antibiotics. How do I manage women and how do I reduce the risk of babies getting this GBS? So should rupture of membranes in a female at term, so basically PROM अगर है, term female है, she has already turned 37 weeks and she has leaking of membrane, she has leaking per vaginum, should she be given antibiotics? The answer lies in the women who are known GBS carriers should be offered IAP. Whereas if a female status is not known, then you can wait up to 24 hours. Induction of labor can be immediate or it can be waited up to 24 hours. And after 24 hours, induction of labor is appropriate. I personally, after 37 weeks of gestation, believe that immediate induction of labor should be done because the longer you wait, there is a higher chance of the infection occurring. So, though the guidelines say that you can wait for 24 hours up to for spontaneous onset of labor, but in my practice, I do not do that. If a female is coming to me after 37 weeks, she is leaking of membranes, then I immediately induce her with dinoprostone gel. So the same thing, if she is known to be colonized with GBS, then she should be offered immediate antibiotics. Otherwise, women should be offered induction of labor immediately or up to 24 hours after spontaneous rupture of membranes with unknown carrier status. अगर female तुम्हारे पास आई है and who is known to have GBS, then you immediately induce her, you do not wait for 24 hours. How should females be managed with known or without known GBS if they are coming in preterm? So remember that female, if she comes in preterm labor, irrespective of her GBS ka status, you know or you don't know, give her antibiotics because preterm labor in itself is a risk factor for the presence of GBS. So if a female is coming to you in preterm labor, definitely give her antibiotics. Do not think about it. Now, how do I manage women? How is the management of preterm labor patients with PPROM to reduce the risk of early onset of GBS? So, female who's coming to me in preterm labor with premature rupture of membranes, bacterial testing is not indicated, is not recommended क्योंकि अभी कुछ point नहीं है. She has already had preterm labor, she probably is already having a risk factor. Bacteriological testing will only delay me from giving her antibiotics. So IAP should be given immediately once the labor is confirmed and the labor should be induced irrespective of the GBS status. I repeat again and again, preterm labor अगर तुम्हारे पास आई है, immediately induce करो. I'll just write it over here. If a female, a pregnant female, she has rupture of membranes, if it is at less than 37 weeks or if she has at more than 37 weeks, more than or equal to 37 weeks, अगर इसमें आई है उसको immediately antibiotics दे दो. अगर more than 37 weeks पे आई है, so if she is a known case of GBS, तो दे दो, अगर नहीं पता है GBS का स्टेटस तो देने की जरूरत नहीं है. द पॉइंट हियर इज दैट प्रीटर्म लेबर में अगर आए तो इंट्रापार्टम एंटीबायोटिक्स देना ही है. डू नॉट थिंक ओवर इट. So what are the appropriate swabs that have to be taken for this? I've already mentioned that vagina and then anorectal swabs have to be taken. Obviously, you can do it the other way around. So anorectal swab is ideal. How do you transport it? It has to be transported in AMIs or towards medium. ये दोनों में मेजर करना है and 1 to 4 days के अंदर टेस्ट करना है, preferably within 24 hours, because after that the possibility or the chances of isolating GBS reduce significantly. What should be the culture medium after it has reached me in that Stewart's medium? What should I culture it on? So Todd Hewitt broth with nalidixic acid and colistin or gentamicin, basically enriched culture mediums. We add these antibiotics, nalidixic acid, colistin, gentamicin to reduce all other organisms and only to promote the growth of GBS. So Todd Hewitt broth is the answer. You don't need to know anything more about it. The next one is, which is the antibiotic that I should be given? So it is recommended at 3 gram benzathine penicillin, or you can even give penicillin. Penicillin को PN लिख रहा हूँ. Penicillin G can be given. It has to be given immediately after the onset of labor. It has to be repeated 4 hourly until delivery. The first dose should be given at least 4 hours prior to delivery. That is one more point that I shall be discussing later on. कि 4 hours minimum required है for effective action of antibiotics to come on. What if your patient is having possible penicillin allergy? You did antibiotic sensitivity testing and she is probably sensitive to it. Then vancomycin is the drug that is recommended. You can also give cefazolin. I don't think cefazolin is mentioned over here. They have given cefuroxime, but you can also give cefazolin. Now the thing is, cefuroxime is 3rd generation cephalosporin. It is not really that effective against gram-positive organisms. But cefazolin is an earlier class of cephalosporin which is sensitive against gram-positive organisms. So if penicillin, the patient is sensitive to penicillin, then don't give penicillin. Instead give either cefazolin or give vancomycin. Clindamycin is a very good drug for gram-positive organisms, but in the UK, there is a resistance rate of 16%. But in US, it is still recommended. उतना resistance नहीं है. India में it depends on your practice. I believe that clindamycin is still a good drug. अपने यहाँ पे we don't use it that rampantly, so the resistance is probably not that high. But clindamycin, again, a very good drug that can be used in gram-positive bacteria. It also kills all the exotoxins that a gram-positive bacteria will release. How should a baby be managed? Now, assuming we have taken all the possible care, but a baby is born, we don't know if it is infected or not. So you should be looking for a few red flag signs. What are those red flag signs? Abnormal behavior. A baby is consistently crying. It is very irritable. It is irritable because क्या होता है जब नियोनेट बॉर्न होता है, उसको सेप्सिस होता है या फिर उसको GBS हुआ है, what are the organs that are affected? सबसे इंपॉर्टेंट है उसको निमोनिया होता है and meningitis. These are the 2 major manifestations of neonatal sepsis due to Group B Streptococcus. ये निमोनिया के वजह से ये बेबी को होने वाला है rapid breathing. So rapid breathing or dyspnea is going to be seen very often. Subcostal retraction, nasal flaring, wheeze, all these things you will hear. Because of meningitis, the baby is going to be very irritable. It will be crying consistently because of that headache, because of that irritability is going to be crying. It will not take feeds. So the baby will not tolerate feeds. The baby will also have nausea, so will keep on vomiting. Because of meningitis, the baby's body tone will be very poor. It is going to be usually very flabby or flappy baby रहेगा एकदम. Of course, temperatures तो ज़्यादा रहेंगे, so pyrexia is possible. Even hypothermia is possible in these babies due to Group B Streptococcus infection, and there is going to be a change of skin color. It is going to be cyanotic. Cyanotic होगा क्योंकि उसका respiratory system is affected. So bluish black color उसका रहना बहुत ही likely है. So look for these red flag signs after delivery. So if a mother has received Group B Streptococcus के against antibiotics for more than 4 hours prior to delivery, those babies do not need special observation. So अगर बेबी को मदर को मिला है 4 घंटे से ज्यादा हो गए हैं एंड उसके बाद डिलीवरी हुआ है, यू डोंट नीड टू वरी मच अबाउट. सो नाउ आई हैव गिवन दोज एंटीबायोटिक्स and the delivery has occurred. The delivery has occurred within 4 hours of antibiotics or after 4 hours. अगर आफ्टर 4 आवर्स है तो कुछ नहीं करना है, नॉर्मल केयर ही देना है उसको. बट इफ इट हैज अकर्ड बिफोर 4 आवर्स या फिर विद इन 4 आवर्स ऑफ giving antibiotics, then a special care has to be taken. That special care that has been mentioned over here is that you have to monitor it at birth at 1 hour and in 2 hourly intervals until 12 hours, possibly in an ICU setup. The vitals have to be checked consistently, preferably keep the baby in an ICU. Should postnatal antibiotics be given to a baby who is low risk, जिसको नहीं लग रहा है? So it is not recommended for asymptomatic infants to be given without any risk factors. But if a baby is having all those signs, then you should be treating it, you should be keeping it in an ICU and you should be treating it with antibiotics. Finally, should breastfeeding be done irrespective of the GBS status? Breast milk से तो जाता नहीं है, so breastfeeding तो देना है. In fact, antibodies आएंगे बच्चे में तो तुम feeding कर सकते हो. So we come to the end of this chapter. Here there is a small algorithm that I would want to discuss. So we have a pregnant female who should not be given at all is the one who is having an elective cesarean section. So no antibiotics required for a pregnant female who is having an elective section. तो ये क्लास तो रूल आउट हो गया. The other one is जिसको मैं vaginal delivery प्लान कर रहा हूँ. So vaginal delivery अगर मैं प्लान कर रहा हूँ, अगर मेरे पास वो आता है एक बेबी जिसका पहले ऑलरेडी लास्ट बेबी हैड GBS, तो डेफिनेटली एंटीबायोटिक्स देना है. ऑल्सो इफ अ मदर इज ऑलरेडी इन प्रीटर्म लेबर, एंटीबायोटिक्स देना है, सोचना नहीं है. नेक्स्ट इज there is possibility कि मदर पॉजिटिव आई है, the mother carries GBS, don't think about it, offer her antibiotics. Similarly, now the patient has come to me at term, she is having pre-labor यानी PROM उसको हुआ है. If she is known to be a GBS carrier तो देना है. If she is not known तो देने की जरूरत नहीं है. अगर not known है तो GBS देने की एंटीबायोटिक्स देने की जरूरत नहीं है. सो ओनली इफ शी इज अ नोन कैरियर स्टेटस ऑफ GBS एट टर्म, देन यू नीड टू गिव इट. सिमिलरली, इंट्रा लेबर, इफ देयर आर नो रिस्क फैक्टर्स फॉर अर्ली ऑनसेट, इफ देयर आर नो अदर रिस्क फैक्टर्स, देयर इज नो हाइपरपायरेक्सिया, देयर इज नो प्रोलॉन्ग लीकिंग ऑफ मेम्ब्रेन्स, देयर इज नो नीड फॉर प्रोफाइलैक्सिस. Whereas if the female has fever, then irrespective of the cause of fever, give her broad spectrum antibiotics. And finally, again in labor, if she has come and if she already had GBS, then give her antibiotics. The last is अगर accidentally bacteria treat हो गया है, अगर उसको more than 10⁵ है तो antibiotics देना है antenatally भी और intrapartum. Whereas if less than 10⁵ है तो antenatally नहीं देना है, only intrapartum देना है. So that is it about our lecture today on Group B Streptococcus. It is a little tricky, a little complex, but I believe that if you know this, you would be able to treat your mothers a lot better if they come to you in preterm labor. So that's it from my end today on this topic on Group B Streptococcus in pregnancy. If you have any doubts, do comment on this video and do reach out to us on our platform of Conceptual OBG. Until next week, I shall see you again in yet another episode of Guideline Review of the Week. Until then, this is Dr. Aditya signing off.